welcome to the Journal of the American Society of Echocardiography podcast Summer Series 2021, Episode 7. My name is Dr. Amer Johri, and it's my pleasure to present today's podcast. Today, I'm joined by Dr. Laura Mantella, who will be presenting the association between TEE and clinical outcomes after coronary artery bypass graft surgery. Hi, Laura. How are you doing today?
Good, thanks. How are you, Dr. Johri?
I'm doing well. Laura, can you tell us a little bit about yourself, your training, and where you're at these days?
Sure. So I just graduated. I was in the MD PhD program at Queen's, and I just graduated from my PhD. And my research focused on vascular ultrasound as a tool to predict coronary artery disease and future cardiovascular events. And now I'll be resuming med school in my third year in September.
Yeah, so this combined program, MD, PhD, it's a long road, isn't it?
Yeah, 7 years.
Yeah, 7 years, great. And so tell us what you plan to do with this sort of combined degree. What are your thoughts about the future?
Yeah, so my career path obviously is leading down the path of clinician scientist. So I believe I want to go into cardiology and hopefully one day run clinical research, kind of like I've been doing for my PhD. So
that's great. And so what interested you about this particular article before we get into the details? Why did you hone in on this one?
Yeah, so I mean, I didn't do any cardiac ultrasound for my PhD specifically, but we did a lot of vascular ultrasound, and we've kind of seen how that, like doing a carotid ultrasound, can give you a lot of information about the heart and any problems that can go on there. So I thought it was interesting just because TEE is used so widely in valve surgery, but we don't really use it in coronary artery bypass graft surgery. So this article kind of looks at the benefits and risks associated with that and if it can be useful in the future.
That's great. All right. So why don't we get into the meat of the matter? Yeah. So take it away, Laura.
Sounds good. Okay. So as you may know, CABG, it's the most widely performed adult cardiac surgery in the US. It carries a low risk of death. However, increasing PCI use, like stenting, has increased the age and subsequently the risk of the CABG population. TEE, or Transesophageal echocardiography, is an ultrasound technique that provides continuous intraoperative hemodynamic monitoring. It's used pretty much uniformly throughout the US in cardiac valve surgery, but not isolated CABG due to unknown benefit and possible risk, such as esophageal perforation. So this study sought to determine whether TE was associated with 30-day mortality in CABG patients. And the secondary endpoints included the composite outcome of 30-day mortality or stroke, length of hospitalization, or esophageal perforation. And then the authors hypothesized that TEE would be associated with improved clinical outcomes. This was a retrospective cohort study using both hospital and surgeon matched pair analysis. So this meant that differences in baseline covariate characteristics were minimized while maintaining a large difference in TEE preference. So for example, hospitals were matched if they were of comparable size, had similar surgical volumes, etc., but opposite TEE preferences. Administrative data on Medicare beneficiaries undergoing isolated CABG was collected between January 2013 and October 2015. And the population included all fee-for-service Medicare beneficiaries with claims for isolated CABG surgery who met the inclusion criteria. And as I mentioned, the primary outcome was all-cause 30-day mortality. And the secondary outcomes included the composite outcome of stroke occurring within hospitalization or 30-day mortality, the length of hospitalization, and the incidence of esophageal perforation. So they want to look at the benefits and the risks. So this is a figure published, the study design. And this was how the matching worked. So the blue indicated a hospital level match and the yellow is the surgeon level match. Altogether, hospital level analysis included about 91,500 patients from either high or low TEE preference hospitals, and the surgeon level match included about 92,200 patients from either high or low TEE preference surgeons. Table 1 from the paper is the baseline characteristics. And this is in the unmatched population. So we see numerous differences between the TEE and no TEE preference populations. The TEE population generally is higher risk. They have increased arrhythmias, congestive heart failure, hypertension, obesity, pulmonary and renal disease. And TEEs are also most often performed in teaching hospitals with more full-time nurses and higher surgical volumes. So quite large differences in the two populations. But despite this, even in the unadjusted, unmatched analysis, the authors showed that patients with TEE had lower 30-day mortality rates, lower incidence of the composite outcome, and no difference in length of hospitalization or esophageal perforation. So then they did the hospital level match, which was their primary analysis. And after the hospital level match, all covariates had standardized differences less than 0.1 and p-values greater than 0.5. So this just meant that there was no difference between the baseline characteristics of the high TEE preference and low TEE preference hospitals. And unsurprisingly, it showed the same results in that there was decreased 30-day mortality and composite endpoint incidence in the high TEE preference group, and no difference in hospitalization or esophageal perforation between the two groups. So just to conclude, among adults undergoing isolated CABG surgery in the US, monitoring using TEE was associated with lower 30-day mortality, lower incidence of stroke or 30-day mortality, and no difference in the length of hospitalization or esophageal perforation. So the author suggested that TEE may offer a clinical benefit to cardiac surgical patients undergoing isolated CABG surgery. I think that's the last slide.
Great. Thank you for that nice, quick summary of this interesting paper. Can you remind us, is this article currently in the in-press section or in the online current issue of the Journal of American Society of Echo?
Yeah, this one's in the current issue, so it's accessible to everyone online right now.
Okay, great. I have a few questions about some of the methods. How did they decide on who was a high preference or a low preference TEE hospital? Did they go into that in any detail or provide us with any information on deciding who goes into which box?
Yeah, so this was all done based on billing codes, I believe, and they published a very extensive supplementary data where they outlined all of their methodology. So I just direct listeners to that to get the detailed explanation.
Okay, and so what are your thoughts on the fact that some of the patients seemed sicker in the academic hospitals, I guess, at baseline. And despite that, they had better 30-day mortality. Do you think it's all because of the TEE, or is it because of other processes occurring in those hospitals?
Yeah, so I think this could have gone two ways. Firstly, these patients are sicker, but perhaps that's why they're getting the TEE in the first place. Like, it's not necessary, like the hospitals are high preference and low preference, but it's the sicker patients that are getting the TEE. So the authors stated that it could have been that when they did their analysis, we see the TEE is actually increasing 30-day mortality, not necessarily because it has anything to do with TEE, but just like you said, these patients are sicker. The other way the author said it could have gone is because these are generally academic centers with more resources and perhaps different post-op care, then we see an actual decrease in 30-day mortality. So there are a lot of confounders that were presented in this paper, a lot of limitations in the discussion sections. I think the authors did a great job of discussing that. But yeah, so I think we overall just see that what we're seeing is not necessarily because of the TEE itself. I think the TEE is definitely playing a role, but we also see that this is just being done in large academic centers with different resources.
Okay. At the beginning, you also showed that there was a distinction between surgeons who prefer TEE versus surgeons who don't. And were these surgeons at different hospitals? So they could be at hospitals that prefer TEE versus hospitals that don't. And what were the outcomes between those two types of practice providers?
Yeah, so the surgeons could have been from different hospitals all throughout the United States, but they did show the same results with the surgeon level match, that again, we see lower 30-day mortality, lower incidence of the composite endpoint, and no difference in hospitalization or esophageal perforation. So yeah, the same data, the same results were shown with the surgeon level matches.
Okay. And why do we think that TEEs associated with these better outcomes? Are we speculating on the fact that we're picking up something that could go wrong during the operation earlier on, or we're getting a better view of the heart, or what are some of the reasons that the authors may speculate as to why TEE seems to be beneficial for this population?
Yeah, so I mean, you're an echocardiographer. I'd be interested to get your opinion on that after, but I think that it could be because we just get hemodynamic monitoring and we get to adjust like intraoperatively what the surgeons are doing in the surgical path. However, there is this potential limitation that the intra-op TE could be identifying valve disease, and they could be doing a concurrent valve replacement, and that is significantly altering 30-day outcomes. But I'd be interested to get your take on that, Dr. Johri.
Yeah, so as mentioned, I haven't studied this in a systematic manner, and so I would think about what can go wrong during a bypass operation and how TEE might be helping in that situation. And so whether there's been damage to other structures, so perhaps the TEE can prevent that from happening in the first place. Also, perhaps it can pick up on any damage that might happen during the operation to other structures, or if there's ongoing bleeding, if hemopericardium develops, or blood or fluid around perhaps even the aorta, that might be useful information to monitor during the operation and providing that feedback to the surgeon. The other thing, during my involvement with surgical operations and providing TEE support, which has been mostly with respect to TAVI and interventional procedures, is the opportunity to give the operator ongoing communication and feedback. And I think it really highlights the team approach that's provided to an operation, and I think we all generally agree that a team approach, a heart team approach to any patient, it would make sense to result in better outcomes. And so then the other thing is that when we look at something that can go wrong post-operatively, quite often we use echo, whether it's transthoracic or TE, to figure out what's happening with them post-operatively if they're not doing well. And having that information during the operation, that baseline imaging, gives us a comparison to maybe better diagnose what's gone wrong with the patient post-operatively. So I would speculate that's probably what's happening with the use of bypass operation, with the use of TE during bypass. And so it's interesting to see whether guidelines would suggest that all bypass operations be supported by TEE in the future or not, or whether that's where things are going.
Yeah, so just based on that, I'd like to get your opinion on, do you think it's feasible? Like, can you speak a bit about at your hospital, if you have enough echo fellows, echocardiographers to be doing TEs with every CABG? And is the TE itself logistically difficult? Do you think we could get the same results just doing a pre-op echocardiogram?
So that's a great question. With the centers that I've worked at, it's the cardiac anesthetists that are doing the TE, so they have this additional training. And so it doesn't have to be the echo team necessarily that gets involved. And we have a very supportive, collaborative relationship with them, so that if they have further questions, then we can just pop into the room and support them. So again, I think this is probably something easy for academic centers to do, because the anesthesiologists are very interested in providing monitoring data, and it helps them with monitoring of the patient during the operation. And they acquire additional training to be cardiac anesthesiologists with respect to supporting these operations. So in that sense, if you have trained anesthesiologists there, then that's, I think, the key ingredient to providing the support to bypass operation. Unfortunately, I would say that no, we do not have people like that at every center. I think it would be difficult for an echo person to necessarily provide that type of support. For example, when I'm thinking about being the reader of the day, it would be very difficult for me to block off the entire morning and be in the operating room when I also have to be supervising stress echoes and transthoracic echoes. So it's all about scheduling, and it fits better with the package that the anesthesiologists perform during their support of that operation.
Okay. And so this study looked at kind of the benefits and the risks, the major risk being esophageal perforation. Are there any other complications you worry about during a TEE that maybe could have been addressed in the paper, or is esophageal perforation the big one?
I would say that's the big one. And generally, esophageal perforation is pretty low, so even outside of a non-operative setting. And so we're not too concerned about that. I'm really glad that they looked for that, and they showed that there was no increased incidence of perforation, because that shows the safety of TE during this operation. The other thing you think about is aspiration, but these patients would be intubated, they'd be NPO, so it's less of a worry. But certainly that is a issue that we deal with during patients that are not necessarily having an operation and we perform TE. So those would be sort of the main things that we look at. Generally, TE is pretty safe. And, we ask screening questions. Risks include things like a history of esophageal varices, for example, or if they've had swallowing issues in the past. So does that suggest strictures? So they are screened for some of those conditions that may not make TE safe. And then they may, in fact, need to be investigated before TE is performed. So that's an important question, because if these patients are routinely going for TE with their bypass operation, then the anesthesiologist would be sure to ask those questions. And there may be, you can envision a scenario where they may decide to get, for example, a barium swallow or further investigations that might slightly delay whether that operation is to be performed if the plan is to have TE at the same time. So that may be an implication for the patient.
Right. So it sounds like there are a lot of benefits for using TE in CABG, but it may actually increase the cost more than just the TE itself, because these patients have to be cleared for a TE in the first place. So I think that when I was reading the paper, at least, I thought that a feasibility study would be useful in the future.
Yeah, I think with a lot of these things, you have to look at the big picture, in that if it's lowering 30-day mortality and lowering incidence of stroke, then overall, even though you've done a little bit more upfront, overall is the cost savings better, right? There was no difference in length of hospitalization, that's fine, but in terms of other complications that might occur after bypass operation, have we saved the patient from those occurring? And so perhaps a true health economics analysis would show that adding TE up front would in fact be overall cost saving.
Yeah, for sure. My last question that I had when I was reading the paper was kind of, what is the ideal design for a study like this? Because you want to get a large population of patients, and you need to match them, because we saw that the baseline characteristics of patients getting TEEs and no TEs are so different. But I think with the matching, and the authors mentioned this in their discussion, sometimes there are factors that are unaccounted for that may substantially improve outcomes. So some of the things that I mentioned when they did the hospital matching were size of the hospital, volume of patients, etc. But they didn't take into account such thing as the technical aspects of the OR, the machines that they have, the staffing, like the post-op care, the experience of the nurses, etc. So, I wonder how that plays into it, and if we can ever get a perfect.
So that's a great question. And, that was related to whether different practice plans at different hospitals are coming into play, resulting in different mortality, also underlying population, whether, some regions have an older population, and so they just have patients that don't do as well, and it may not be related to a TE. So as you know, one of the strongest designs for a research study is the randomized controlled trial. So you could envision that you have one hospital that has all other variables held the same, and the patient is just randomized to either getting a TEE or not in the OR. And so when you're performing randomization like that, the way to get ethical approval to making sure that it's ethical to randomize someone to not get a TE would be if there is clinical equipoise, if we're really not sure that TE is 100%, fully safe or fully advantageous. You want to have that equipoise. And then you can sort of argue, well, we know tea is not harmful, as shown by this study, for example. We think it might be beneficial, but there's no guideline that's saying that everyone has to get TE. So then it would be ethical to randomize someone to not get a TEE if the patient also consents to that, right? And if it's not already established as the standard of care at that center. So that would probably be the best design that would control for some of the confounding factors. And then I would like to see that conducted in a multi-center study. So that would be my approach to definitively answering that question. Yeah. I don't know whether there's a strong reason to do that or not. I think what's probably happening is that the use of TE is limited by resources. And so generally it's accepted that TE provides more information, it's probably helpful. This study is really good in showing that it's beneficial, in fact. And so the issue is, do I do that? Does the setting have the resources and the training to do TEE more often in bypass operation? Okay. I think the takeaway point from this paper, which is really interesting, is that when you're leaning towards doing a TEE or not, this paper suggests, yes, go ahead and do the TEE if you have the resources there. So I think that would be the takeaway point. I don't think we're at that point that we can mandate TEE needs to be used in bypass operation right now.
Yeah, I completely agree.
Yeah, great. All right. Well, why don't we end there? I appreciate you, Laura, taking the time to going through some of the interesting aspects of this paper. And I would encourage our readers to download the paper as well in the recent issue of the Journal of the American Society of Echo. And we look forward to presenting another episode of the JASE podcast to you next week. Thank you so much, Laura.